Hello, everybody. Good afternoon. Thank you for coming out today. I'm Dr. Christopher Hollowell. Many of you in here are patients already here at Z Urology and of mine. Some the first time we're going to meet. But we're going to talk about today Resume, which we're here all to hear about, which is a really exciting new technology. And I'm very excited to talk to you about it and go in more details. So for the sake of the talk itself, if we could save all your questions for the end, and then I promise I'll give time for everybody to write them down if you need to, and then we'll go over each one of your questions at the end of the talk. So we're going to try to go through this. There's kind of a lot of stuff we're going to cover here, and hopefully it will be very educational for you. So we're going to talk about the problem of BPH itself. We're going to review some of the minimally invasive therapies, some of the historical ones, and the position of Resume in the marketplace, and the design and procedural overview. We're going to go over some of the short-term data and procedural animation, and then the future of this technology in terms of where it's going to go from BPH. So there's 12 million men in America that are diagnosed with BPH even already, but that's going to be a low number. It's probably going to be a lot more than that, given that baby boomers are getting older, we're living longer. So most people are going to have issues with BPH. I like to think that everybody's going to have problems with BPH sooner or later. If you live long enough, every man's prostate grows, and as it grows, you're going to have issues generally as we get. As you can see, this slide shows that 50% of men at the age of 50 start having the symptoms, and everyone just about by the time they're 80. And the reason for that is when you're born and testosterone imprints your prostate at about puberty, the prostate keeps growing for the rest of your life. So that's going to depend. Some patients' prostates grow bigger and some grow faster. That's all up due to your family, so you can blame dad for that, you know. So that's really kind of the issue, is that as the prostate grows, and we'll show how that the anatomy causes these issues, we're going to have problems with passing our urine. So what is the prostate? Where is it? What is the function of the prostate? And what is relevant anatomy? And we'll go over these. So the prostate is a gland, muscular vascular gland that sits at the base of the penis, at the base of the bladder, excuse me, and you urinate through the middle of it. Now, the prostate when you're 20 years old is probably about the size of a walnut. But as we get older, it can get a lot bigger than that. And it grows gradually, and like I said, everybody's different. Just like some women have bigger breasts than other women, some men have bigger prostates than other men. This is just really more to do with family than anything else. The function of the prostate is that it is a gland which produces the semen and expels it. So most people think when they ejaculate that most of it's sperm that comes out. Actually, very little is sperm. In fact, when we do vasectomies on patients, they lose very little volume because most of the fluid that's expelled is prostatic fluid and these two little glands that sit on the back of the prostate called the seminal vesicle. So as the prostate enlarges, you can see the normal prostate here on the left where the urine travels through the channel of the prostate here. And as the prostate enlarges, it impinges on the actual urethra or constricts it, so it restricts the flow from the bladder out through the penis here. So I want to really emphasize that BPH, or enlarged prostate, is non-cancerous. Everyone thinks my prostate's growing, doc tells me I got a big prostate, I know cancer grows, so I must have prostate cancer. So they have really nothing to do with none of it. In fact, most prostate cancers are in smaller prostates, actually not in larger ones. We think that the growth of the prostate is something protective, that most of these big prostates don't actually have prostate cancer in them, just like a woman with bigger breasts would not necessarily have more chance of breast cancer. So as the prostate grows, it restricts the flow, and that actually is what causes the symptoms. So what happens is the growth causes this. The bladder has to squeeze harder to eject the urine. As the bladder squeezes harder, the bladder thickens. So as the bladder thickens, the bladder can't stretch up like it normally does, and you go more frequently to the bathroom. So I made this cartoon so you can kind of see this. I like to think of the prostate like a donut. You pee through the middle of the donut. If the donut grows outward, you just have a big donut. It's not that important. But if the whole of the donut closes up, you got big problems. Okay, so that backs up. The bladder has to work harder, and as you can see, the channel is restricted. I have sometimes guys who have big prostates, size of coconuts, and they can hit that wall over there. But the guys with little bitty prostates and can barely pee, because it's the inward growth of the prostate, not the outward growth, that's important. So the symptoms are from the bladder mostly, because it's obstructing the bladder thickens, so we get more frequent urination, especially at night. The reason at night, so that's how it starts, is because when we're sleeping it wakes us up in terms of that urge to have to go. Then as the prostate puts more pressure on the bladder works harder and thickens, the bladder will start carrying over during the day, where you'll start notice frequency during the day. You can't consciously consciously divert having to go to the bathroom. It just tells you need to go. Straining to void, a slow, weak stream, burning at the tip is some of the things that we can feel, and a feeling of incomplete emptying, meaning that I feel like I went to the bathroom, but I still feel like I have some left over. So I like to think of this slide as my as the sunny side of the hill kind of slide. And what I want to kind of emphasize is the position of minimally invasive therapies are always going to be in the beginning stages. Now what happens is that as your prostate grows and that hole closes up, it gradually closes. It doesn't swell up on you overnight. So as it gradually closes, the bladder works harder over time and the bladder thickens. We already established that. So the symptoms start to kick in. So that's when you start getting up 3 times a night, you're going a little frequently during the day, your stream is getting a little weaker. The bladder is compensating. Now the bladder is a muscle. It's different than this kind of muscle. God built this muscle, this is skeletal muscle, that when we strain it, it gets bigger and stronger. The bladder is a different kind of muscle. It's called smooth muscle. And smooth muscle is a lazy muscle. It does not want to work hard. In fact, just like our veins, when it's cold outside, you can see the veins are smaller, and when it's hot outside, they expand. That's the thermostat that's built in for our skin. So this is smooth muscle, and it's very weak muscle. But if I strain it and I block it, it will work harder. But as it works harder, it damages the bladder. So unlike this, as it gets bigger and stronger, the bladder gets weaker as time goes on. So as the bladder has, over the years, have struggling against that obstruction, the bladder, what we call, decompensates. So what we want to do, meaning that it actually damages or dies, actually. Just like a heart. If I block the heart will beat stronger and harder to eject it. But after a while, you go into heart failure. It won't function anymore. So what we want to do is offset people on the sunny side of the hill, right? So when the bladder is compensating and not necessarily damaged yet, not on the dark side of the hill once it starts to get damaged. Now what happens is, we traditionally as urologists, in the old days, or for many years, what we use for treatment is the transurethral resection of prostate, or TURP is what a lot of guys will call it, Roto-Rooter job, reaming out job, it's all the same. And essentially, this particular procedure, we generally will wait, because it is a surgically invasive procedure, until the wheels are falling off, until guys are really far down this path. And so sometimes we're actually getting to patients later on where their bladders don't recover from this actual. So what we want to try to do is affect the patients on this side. Go ahead, Jane.
Oh yeah, we don't need to. We don't want to do that. You know, my kidneys feel a lot better in this position. Maybe it's just that I'm not doing any calisthenics.
So I love this clip. It's from Fletch. And this is how patients think of me when I'm examining them.
You ever see her time? Matter of fact, you using the whole fist off? I can't discuss it with this patient, you know that. Well, I don't find anything wrong with you. Well, sure it's not for a lack of look.
All right. So the way we diagnose the prostate is, first we want to do some tests and questionnaires. So we get a blood test called a PSA for the prostate. It screens you for prostate cancer. Creatinine, which is the CR there, it's your blood test that monitors you for your kidneys. Avoiding diarrhea, you'll sit down and you'll tell me, well, I go at night, I go this many times during the day. We write it down, because sometimes we forget. And so when you measure it and write it down, you'll be able to kind of give a more accurate picture of what's going on. Prostate imaging, so when we look and do a cystoscopy, I always think of cystoscopy where they're depicting this as I'm taking a telescope. I don't use my eye anymore. We have TV screens now, but when we look inside the bladder, it's kind of like me shaking your hand. It's like looking at the anatomy itself. So again, almost everyone in here, if they haven't got cystoid by me, they're going to get it sooner or later. And an ultrasound of the prostate. Sometimes I'll use that to show me the size and the configuration of the prostate. And then what we do is a post-void residual, which means how much is left in your bladder. So greater than 100 in a man, so it's different in a man and woman, greater than 100 in a man is significant. And then we go with the flow rate. So when I have you guys pee in the room, in these little urinals in the room, I'm not doing that because I just want you guys to pee in front of me. I have a special computer that's watching you pee, and it tells me at how fast that you pee, at what tenor at which you pee, and also at what speed at which you pee, and then how much that you actually volume that you peed. And so all those things are important information for me to kind of see how, if you're going slow, if you're having to push to actually urinate. And obviously the rectal exam, which Fletch just so eloquently showed us, and prostate size. So greater than 30 grams, it's starting to show that it's getting bigger as time goes on. Now the IPSS scores is a score that my governing body, the American Urologic Association, has come up with. It's a way that we can kind of standardize patients' symptoms. So there's a series of 7 questions and then the quality of life questions. And it gives me kind of this numerical number that I can quantify so that I can say, here's where you stand as opposed to other men in terms of their symptoms. And we use that to help gauge where you are. And anything greater than, let's say, this is actually wrong, it should be greater than, let's say, 20 or so is going to be significant. So BPH in terms of the natural progression. So almost everyone I start on medications. And the reason for that is because we want to make sure that we're doing the right thing for you. So many times we give you the medications, we see how you do. Now, some patients don't want to take medicines. Some patients can't tolerate them because of side effects. Some patients can't afford medications. And so these are all important things that I have to kind of take into account when we're going down this progression step. So I think that where the minimally invasives are, they're actually equal with oral medications. So what I mean by that is it is a first-line therapy where we can just sometimes start with the medicines or forego it. Some men will just come to me, I don't ever want to take medicines. I don't take medicines. I don't want to have to take them. Is there anything that we can do so that I don't have to take them in my lifetime? And so we can just say, go straight. We would never go straight to surgery. That would just never happen in a urologist's practice. So that's what's great about these because of their positioning in terms of where we can do this on the sunny side of the hill, where we can affect patients early on.